One of the challenges that I face as a retina specialist that I think MicroPulse addresses nicely is the treatment of diabetic macular edema. There is various approaches to diabetic macular edema with pharmacologic medications, but I think that laser has a very strong role in the disease, and I like MicroPulse Laser because it's non-destructive and reliable, and I think that it's effective in diabetic macular edema. MicroPulse has been a great addition to my use of pharmacotherapy. I think that there are cases and criteria where focal laser or MicroPulse focal has a significant role in treatment of retinal disease, and I utilize MicroPulse almost exclusively in those cases. If I had a colleague who was skeptical about MicroPulse, I would say that they should probably try it. There is some data documenting the efficacy, but I think that further trials are upcoming, and I think that as the technology catches on more and more, there'll be more and more studies that demonstrate the efficacy of MicroPulse side to side with other modalities. The ideal candidate for MicroPulse laser therapy is a patient with either diabetic macular edema that is not so significant where it is amenable to focal laser. So I would use my usual focal criteria, but I use MicroPulse exclusively in the cases of diabetic macular edema. In my experience in central serous chorioretinopathy, if you have patients with chronic fluid, subretinal fluid that doesn't go away, those are good candidates for MicroPulse, and in those cases, I will treat the entire pocket of fluid, including subfoveal fluid, because the laser is not destructive and helps expedite the reabsorption of fluid. I would say those two are my two top indications. I explain MicroPulse to my patients. I tell them that the small blood vessels, the small capillaries in the center of the retina are leaky because of whatever disease they have. And we found that laser tends to affect the retina in a way that makes it reabsorb the fluid more efficiently. And that with this new laser, they're not going to have a blind spot or a scotoma, and it's a worthwhile thing to try because there's no risk of infection like there is with intravitreal injections. And of course, all my patients are up for it. I think that the treatment of macular edema, especially diabetic macular edema, is very complex. It's hard to answer in a vacuum a protocol for a patient without knowing the rest of their history, their hemoglobin A1C, their glycemic control, whether they already have end organ damage with heart attacks and renal failure, because patients who have all those things probably have a much worse disease than those who don't, and I'll be much more aggressive in treating someone with a hemoglobin A1C of 14 who has mild or the beginnings of diabetic macular edema versus a patient who tells me that they've now controlled their diabetes. Having said that, in uncontrolled diabetic patients, I'm much more likely to treat diabetic macular edema with MicroPulse early on. When I first started using the MicroPulse laser in my practice, I very quickly switched from doing all my focal lasers from standard focals to MicroPulse focals, and I have not done a standard focal on a diabetic in 2 years. I think one of the best things about MicroPulse laser is when you're teaching residents or trainees, because you know that there's not a risk of them causing serious structural damage to the macula by making a mistake. When in the old days of teaching laser, we would stand over them and watch their settings and all that, and we still do it, but I like the certainty that nothing damaging will be done to the macula or the retina as long as I know that that MicroPulse setting is on. And with the new technology where you could actually visualize what's going on as the observer overhead with the photographs and the videos, I think that's even more helpful, because when you're looking through the assistant scope, sometimes you're in a funny orientation, you're not sure where they are and where you are, but with this you'll really be able to see what they're doing. A MicroPulse laser is safe. The laser system itself is portable, which is very important to me and doesn't take up a lot of space in my office. It's very reliable and user-friendly. It's very easy to figure out what setting you're in or to adjust settings. I never had to really read any manuals or anything like that. It's very intuitive. The value of working with Iridex is tremendous. I think Iridex is a great company. And from the first days that I became an ophthalmologist, I was using Iridex lasers. They're known for being extremely durable and lasting for years and really delivering a quality product. All the people that I've interacted with at Iridex have been wonderful, kind, and really knowledgeable. And if I have a question or an issue that somebody doesn't have a response to, people get back to me right away. So I've had nothing but the most positive experience with Iridex as a company, and I hope they keep it up. More and more there's studies and research about using pharmacologic agents, and I think the pharmacologic agents are absolutely essential in treatment of macular edema, diabetes. However, I think that we're dealing with a patient population that has poor compliance, poor follow-up, and the way that people usually end up with really bad diabetic macular edema or diabetes is by not following up and not coming to their doctor's appointments and not being compliant. And I think that when I see a patient with something like severe non-proliferative diabetic retinopathy, even though there's studies that may tell me that if I'm injecting them with pharmacologics, they won't advance to PDR as quickly, more likely than not, if they're lost to follow-up with me, they will come back with a vitreous hemorrhage and a missed opportunity to have treated them with PRP and prevented that from happening, or worse. So I think that laser still has a role in the management of various retinal conditions, and I don't foresee that changing anytime in the near future.